Hello and welcome to YHTV's Magical Medical Tour. This is episode 49. Thank you for joining us today. I'm Christina Suzuma, and with me is our wonderful medical guide, Dr. Glenn Woolman. Good day to you, Dr. Woolman.
And a wonderful day to you, Christina. How are you?
Great. It's I have to say, it's like spring is in the air this morning here in LA. We went for our morning mile and the birds were chirping, the hummingbirds were singing. It was magnificent.
I think we're going to break into song and dance here.
Yeah. Yeah, but it's been so cold. And then suddenly to have this glorious morning, it's just fabulous to wake up to.
I know. Greetings, everybody, and welcome to Magical Medical Tour. I'm Dr. Glenn Woolman. I will be your host along with Christina as we spend another week in the healthcare galaxy searching for optimal health. Yeah, spring is in the air, and I like that, but I think it's confusing to all my plants and flowers and everything. You know, you get spring and then another winter comes, and then spring comes, and then the flowers seem to not know what to do.
Oh, it's been a really rough year. I have not seen a year quite like this in the 20 years I've been here. And I know in the farmers market this last weekend, we were talking about it. The poor farmers, I mean, their crops are really suffering right now.
It's interesting to be someone who is so much a part of weather and conditions and environment as the farmers are. I have to pay a lot of attention to that. Christina, special show today. Special show today. I have a long time friend and colleague, Dr. Richard Goldman, who will be speaking with us today and having a conversation. He has a great story. Started out in taking his residency in family practice and then went into emergency medicine. And then
he's one of you.
He's one of us.
Yeah.
He's one of the peeps. So we might have some good stories there to look at. But he, like many other people, and part of what we talk about on the show of different variations on a theme and different places you can go within the medical field, he went on to palliative care. Those of you that may have heard the term and don't know what it is will learn a lot today, I'm sure. So I think I would, rather than just chat a little more, I'd like to get right to talking with Richard and introduce him to our global audience and to you. How are you today?
I'm well, and I'm hearing you introduce me and going back to all our years. I have to, much like you do when you do a medical talk, you give disclaimers to the different companies that are supporting you. Whatever things I may have to say, I have to refer back to our relationship that goes back 50 years. We were in junior high school together, and so I think the audience should know that this is more than just, certainly for me, more than just a professional discussion we're having. It's just very gratifying and exciting to share your new part in your life, your professional life, as a medical guide, and to be able to be part of that after this long relationship we've had is very exciting. So thanks for having me. Yeah.
Well, we've actually done all of it together: junior high school, college, medical school.
That's right.
Well, medical school as well.
Medical school as well.
Wow.
That's right.
And you're still friends.
Definitely. Well, it's interesting. There was a whole group of us that met early on. I came in a little later than a lot of the friends, but there was a whole group of people that it was a great group of people. All were oriented toward enjoying life, having fun, but being professional and having careers. And we all supported each other and took care of each other through all of that process.
That's right.
So that part of it, I think, was really great. We loved that. Richard, usually what I do as the medical guide is I give our viewing audience a opportunity to have an idea of where I think I'm going with the show. But as you said, we don't know where we'll go today since we have so many possibilities that can be brought up. But I'd like to start out where we talk about just your your journey, how you got into medicine, why you decided to become a healer, where that happened, when it happened, and then through some of the programs that you went through, and then to where you are today. We also want to talk about some stories and some palliative care issues and give people a lot of information in that area. Does that sound okay to you?
That sounds like a great idea.
Okay, so from that point of view, let's start from the beginning and give us an idea of where you started, what got you into medicine. Take us up at least through the emergency department, and then maybe we'll work our way into palliative care.
Okay. Well, just to echo what you said, when we were in college, we were a close-knit group of friends. There were about 6 of us. We lived right near each other in the dorms. And I went to college with the idea of becoming an English major and an English teacher. And you and many other of the close friends were actually taking pre-medical and pre-dental courses. And being at that time not wanting to be left out, I signed up along with it too and started taking the chemistries and the physiology classes and actually went along with it. I'd like to be able to say that, I wanted to be a doctor, as Glenn did, I recall, ever since I remember him. He always wanted to be a doctor, but that was not the case for myself. However, as we went along, it was very challenging, and the time came, and I did apply to medical school and went off to medical school, and have no regrets whatsoever for the guidance and the encouragement and the motivation that was supplied by these friends we had. And I look back, there were 6 of us that were relatively close that first year in college, and 4 of us have gone on to be. 3 of us are physicians. 1 is a dentist. So that path was really very interesting for all of us. So that's how I became interested in medicine. It was my peer group, the peer group pressure. And I succumbed to it, but I'm very happy I did. So I went off to medical school and then did a family practice residency. And then, because it was a means of getting out there and having a certain amount of freedom, emergency medicine at that time offered that. I wasn't married at the time, and emergency medicine provided the opportunity to be very much engaged in a very dramatic and exciting part of medicine. And it also provided an opportunity to have time to travel, to ski, to do different things. So it just really fit very well into my life when I was younger. And emergency medicine continued to be an exciting and meaningful profession to me for decades. As a matter of fact, I practiced it up until about 2000. And so I was at the same hospital in the same emergency room for about 25 years. I was the medical director there. And the interesting thing about emergency medicine, as I look back on it now, among many things, is how different it is from the work I'm doing now. Because in emergency medicine, one really has to take charge and make decisions and give instructions and directions. And the opportunity to listen in those settings is not often there. And that's pretty much 180 degrees from the work I'm doing now. But it has provided me a very broad base of professional information, because in emergency medicine, you have to know a little bit or a moderate amount about lots of different things, every area of medicine. So it really has provided me a good foundation of information for the work that I'm doing now.
Yeah, that's a great story. I'm just thinking back, and if you had more influence on all of us, we'd all be in literature right now.
Well, you're pretty close to that, though, Glenn.
I don't know about that. It would be interesting. Do you do any writing still? Do you still have that interest? Is there anything?
I have that interest, but I'm not disciplined enough to really do it formally. I do every now and then, write down and try to make it somewhat literate, an interesting patient, an encounter that I've had, but I don't do it on a consistent enough basis to go beyond that.
Uh-huh. When did you get into palliative care? When did that happen?
Well, that happened as a somewhat fortuitous opportunity. If one believes that there are no coincidences, then it perhaps wasn't fortuitous. I was diagnosed with prostate cancer in 2000. I was still doing outpatient medicine, not so much emergency. I think I had kind of transitioned a little bit to more of outpatient clinics, but it was pretty much the same type of medical practice. And I was diagnosed with prostate cancer. And as we had been talking about, you and I, just before we started the broadcast, sometimes life presents you education in forms that you wouldn't have asked for. And this was one of those for me. It was very frightening. It made very clear to me what should have been clear, but I think sometimes our minds protect us, that life is finite, at least in this realm, that at some point in time, each of us become that name in the papers, so to speak. When you're reading in papers, something always seems to happen to somebody else. And I had been fortunate and blessed throughout my life to have to avoid any major traumatic, either physical or emotional circumstances. And this was a dramatic awakening, the fact that I am mortal, and the fact that one is not necessarily guaranteed a future. So with this opportunity, once I had the diagnosis and received treatment for it, I was provided an opportunity to explore that in the past and that which I hoped to have in the future. And I came to the realization that if I continued to do things exactly in the same manner as I had done them, that I couldn't expect very different results, because somewhere in the formula of the life that I had led brought me to the point where I had prostate cancer. I don't know what component of that formula resulted in that, but I became aware that I couldn't just go back to doing things in the manner in which I had done them and expect to come out with a different result. So that realization really provided the initiative and the motivation to begin to explore different opportunities. Just at that time, the hospital was developing a palliative care program. They knew me from being there in the emergency room department, and it just fell together that they needed a physician to champion the palliative care service. And it looked like something that I could use, in part because of my experiences as diverse as they were in emergency medicine, and because of some other things that I had pursued along the way that I think served me well in what I'm doing now.
Excellent. I would like to branch off for just a moment and stay with the diagnosis, and maybe that'll segue us into palliative care. But people always think that people in medicine, we don't get anything. We don't understand what it's like to be a patient. We don't understand a lot of these things, and it would be so great if we did understand that. So at the time that you had the diagnosis, how did the diagnosis come first? I want to talk about the prostate cancer for some of our listeners
Sure.
briefly, and then we'll get into palliative care, which we promised. How was the diagnosis made?
Diagnosis was made on a routine PSA at an annual checkup. It was elevated. It had gone up quite a bit from the one I had 2 years prior, and that initiated, the sequence of events of going on and having a biopsy. And then, of course, the biopsy results showing adenocarcinoma of the prostate. I can remember very, very vividly the moment sitting there in front of the doctor on the other side of the desk, and asking me if I knew what the results were. I think maybe he thought I called the pathologist, but I hadn't. And he had the piece of paper there in front of him, didn't say anything to me, just turned it around so I could look at it, and I could, I could see in the dark typescript, adenocarcinoma of the prostate. From that moment on, I'm not sure I heard anything else other than the pounding of my heart in my ears. I was very frightened, in spite of knowing that prostate cancer, if you're going to have cancers, prostate cancers, are probably among the best in terms of outcomes. But that was not what I was able to be in touch with at that time. And so it was a lot of fear, a lot of wondering of what about my future. And it's even difficult to go back and talk about it now as highly emotional and as it was. But it was certainly a valuable experience. And like you say, to experience it from the other side as patients do, I think that there's no way, there are no amount of conferences one can go through. You have to have that experience in some very close fashion for it to be meaningful.
I think it's important what you said before, and we talk about this. I even talk about this when I'm being a medical guide. Even if somebody's just having a surgery, any kind of surgery itself, I always say to them at the end, you can't try and be the same person you were, because that may bring about the same results. So I'm very glad you brought that up. So now you get the diagnosis, your heart's pounding, you're going through a lot of emotional things. Now, as a physician, you know more than a lot of people all of the opportunities and the various potential treatments and therapies. And as a physician, you probably know which one has the yin and which one has the yang. And how did you go about the process of figuring out all the different procedures and picking one yourself?
Well, I made radical changes. I certainly pursued the different alternatives in prostate cancer, and you can get far too much information. Even now, 11 years later, I was just at tumor board, which we have every Thursday in our hospital, and it was just 2 weeks ago that a case of prostate cancer came up, and the different physicians, the oncologists, the radiation oncologists, the surgeons, there's certainly on this issue of prostate cancer, we just don't know what the best treatment is at this point. But I chose a treatment, but I didn't just choose a medical treatment. I mean, I wanted to have a traditional treatment, but I did many other things. I certainly changed my diet. I gave up, for the most part, meat, and have maintained, not a strict vegetarian, but a highly predominant vegetarian diet. I became very active in practicing meditation, something that I had done sporadically since I actually became a doctor. Started doing transcendental meditation in the 70s and did it on and off. But when I was diagnosed, I began to become involved in a more consistent meditation practice. So I approached this from a variety of avenues. I met with a non-medical person, but someone that has a lot of experience. Actually, she was a yoga instructor, Christina. You perhaps would be glad to hear that. And she had a lot of other just very a different approach. I think probably inclusive of many of the things that you, Glenn, and Christina are doing in pursuing health, wellness from the basis of wholeness, and incorporating different modalities and lifestyle changes and levels of awareness. And so I would meet with her on a weekly basis, and she would talk about where certain chakras were blocked and things like that. So I don't know to what I can attribute my good fortune now, 11 years, and my PSA is very, very low. But it was a concerted and diverse effort to do things differently, and to take this scary and fearful opportunity and to you talk about the yin and the yang. For every crisis there is the chance of a new opportunity. So that's what I did. In terms of the actual medical treatment that I chose, it worked for me. And in terms of prostate cancer, I think that's probably the message. Get your information and make a decision that, if you don't like to be irradiated, then perhaps surgery is, your choice. If surgery frightens you, then perhaps, considering radiation.
How about family? How important were they in this whole process?
Oh, I don't know if I can maintain my emotions and talk about it. They're tremendously important, of course, very supportive. It was actually my brother who made a phone call to a friend of his who was a urologist in Seattle that changed the direction I was going in. I was actually going to go for surgery, and it was my brother who made a call to a friend of his who is a doctor, a urologist, and he provided me a bit more information about an alternative treatment, which was radiation, actually what they call brachytherapy, which is radioactive seed implantations in the prostate. And so my family was, tremendously involved, tremendously supportive. It was a difficult time when you have a family. My children were relatively young. My daughter was about 14 or 15. My two sons were, younger than that. And the idea, that fear that, they would be without a father, is a daunting one. So they were very, very supportive, and still are major parts of my life.
Thank you for getting personal with us and sharing some of that. I hope that inspires. I know it's inspiring to me. I hope that inspires other people as they move forward when they're sitting across the desk from the doctor. Let's move into palliative care now.
Okay.
So how about if you first give us a definition of palliative care?
Okay. So palliative care is a relatively new area. It's a medical specialty. There are board examinations in it, okay, and it's been around probably for about 10 to 15 years. When the realization came that, we not only do we live our lives differently, we live longer now than we ever have before, for the most part, but that same dimension of living life longer has created a whole new set of circumstances, because as we live longer and differently, we now die differently. And so palliative care is the area of medicine that focuses on diseases that can't be cured, or what we often call chronic illnesses. In theory, it can involve the understanding, the explanation, the management of diseases as simple and as common as hypertension and diabetes, diseases that we can't cure. But in the actual practice of it, we're dealing with more life-threatening, perhaps knowing life-ending illnesses. And so palliative care provides many dimensions to involving people and families in that, in terms of certain aggressive symptom management. So if you have an illness that can't be cured, it still may have treatment available to it, but not curative treatment. It aggressively pursues quality of life issues by active and aggressive symptom management, be it pain, shortness of breath, whatever symptoms it might be. It provides an understanding, as you go through courses of illness, the trajectory of the illness changes. You go from, my experience of an abnormal blood test and hoping that it's not anything serious, to a diagnosis and the hope that you're going to be cured, and the treatment that would hopefully bring that cure. But in many cases, diseases can't be cured. And as the trajectory changes and the medical management that had been beneficial in the past perhaps no longer provides that benefit, then people's goals change along the way. And so a large part of palliative care is providing information to patients about their illness, about what you might call disease trajectory, about what options there are as things change, and a better understanding of who the patient is and what the patient's values are. What makes life meaningful to the patient? Some patients would say that, being alive is what matters most, and most of us would agree with that, but many of us would put certain qualifications to that in terms of what the quality of life is.
Mm-hmm.
So if we can have a better understanding of what matters to patients, what their values are, then we can integrate that with what treatments are available, because all treatments that are available might not reach that patient in terms of what matters to the patient. And so we provide information in terms of meeting with patients, including their families, and have discussions about these aspects about care. So palliative care involves aggressive symptom management. How I involve myself in it is more in providing communication to patients to create the environment that allows them to live out their lives in the most meaningful manner to them.
Well, that's a pretty good explanation there. I want to get into some more detail, but I'm wondering if, you've had history in emergency departments where we always, when emergency doctors get together, we tell great stories and have all of these experiences. Do you have some experiences that you have gleaned from the palliative care part of your life that would help us to understand what you do more and how people should possibly consider that for themselves and their loved ones?
Sure. Yeah, let me just give a little more context to it. So, so we die differently now. Okay, what does that mean? Well, it used to be that 100 years ago, when we died, death came quickly, in hours or days. Medicine didn't have very much to offer. Death came from an accident, or very often from an infection. We didn't have even antibiotics 100 years ago. The family at that time were the caregivers. We lived in a nuclear family. Parents, grandparents, sometimes aunts and uncles. So families were the caregivers, and doctors were minimally involved. They've only been able to offer pain relief really in the last 2 centuries. And so the focus of care from medicine was really on caring and what comfort could be given. The family were often the caregivers, and death occurred not in hospitals or nursing homes, but at home. And then with the advance in technology and science and antibiotics and anesthesia and surgical techniques and public health and vaccinations, we live longer, but we die differently. So death now takes a longer period of time. It can be months or even years that people are dealing with chronic illnesses. And the deaths, of course, happen more in hospitals. And it's associated with so many different aspects now that we're only now beginning to get an understanding and being able to deal with. So as we go through this prolonged period of living with chronic illness, moving towards the end of our life, we have now this opportunity to have multiple chances of suffering on many levels, physical suffering and with symptoms, and psychological sufferings of anxiety and depression, despair, or feelings of hopelessness, and social suffering, you might call that, where you feel isolated. You get a serious illness and you're somewhat isolated as it moves towards the end. The peripheral friends are on the periphery, and there's a sense of isolation, and certainly financial burdens are a major part. And it brings up, of course, spiritual issues. What is the meaning of my life? Did I lead a productive life or a meaningful life? And it brings up ethical issues in terms of who makes decisions, utilization of resources. So palliative care actually focuses on many of these issues, and let me tell you a recent consult that I have that I think could perhaps more poignantly demonstrate this. Okay, do we have a few minutes for this?
Long as you need.
Okay, so this was a 58-year-old man that I met with 2 weeks ago. Okay, and he had what we call end-stage emphysema, or COPD, a breathing disorder from smoking. Smoked all his life. And when I saw him, he had been in the hospital 5 times in the last 8 weeks because his breathing kept failing. He couldn't stay out of the hospital more than a week. He was really moving towards the end. And he appeared very, very ill. He had lost weight. And he was sitting in bed, and I approached him and introduced myself to him and asked him if he, was willing to have a conversation. His doctor had asked me to meet with him and his family, and he said, "Yeah, whatever, sure." He didn't make any eye contact with me, but we went ahead, and I met with him. I have my team of a nurse and a social worker, and we often have a chaplain on the team, and he was there with his wife and his 18-year-old son. And I asked him about, what his perception was about the change in his life related to his illness. And he said, well, things have been about the same for a couple of years. And I looked at his wife, and she rolled her eyes up and indicating, no, that's not the case. And then he said, well, I've had pneumonia recently, and that's taken my energy. And he really made no acknowledgement about the underlying disease of emphysema, which had led him to this point. And so then I said to him, well, do you need, help with any activities around the house? And he said, no, I can do them myself. And again, his wife rolled her eyes and said, no, he needs help, but he won't ask me for the help. He gets so tired, and then he has to ask me, and of course I help him. And so I said to him, well, this must be so difficult for you. I mean, these changes in your life, that this lack of independence. And he turned and gave me a stare, no response. And I'm wondering, is he angry at me for mentioning that? Is it a dumb, obvious statement that requires no response? Is there uncertainty on his part, some inability about how do you respond to questions like this? How do you talk about this? So I then proceeded to say, well, tell me what you understand about your illness. What have your doctors told you? Well, they don't tell me anything. They don't talk to me. Well, is this information that you'd like to have? Sometimes you have to check in with the patients because you don't know where they are emotionally in terms of understanding and dealing with their illness. And so you want to respect their feelings and not provide them information that they're not perhaps ready for. But he said yes, he would like the information. And I told him about my concerns that this recent repeated hospitalizations were indicative of a significant decline, and that things were rapidly moving to a critical level. And so I asked him, what concerns you most when you hear this information? And that opened up the gates. And he said, with a lot of emotion and anger, of course, on his part, well, I'm concerned about how I'm going to make a house payment. And I'm concerned about that I've depleted my savings and my 401k. And I'm concerned about how is my family going to get along and where they're going to live if I can't make a house payment. And I'm concerned about who's going to take care of me if I get worse. And I'm about being dumped in a nursing home in the last days of my life and not being able to wipe my own butt. And he went on to talk about how he had worked 20 years in a business. He was a parts man, and he had to stop working 4 or 5 years ago because he became too symptomatic. And all those years of being able to provide to his family and being vital to them and fulfilling his roles and his responsibilities and having meaning in his life, all this stripped from him. And here he was, really literally skin and bones with an oxygen tube sitting in a wheelchair. And after that, there was silence. One of the difficult things in doing this is, as a physician, we like to do things for patients. That's what we're trained to do. We're trained to cure and to help. And certainly in the emergency room, I think that dramatizes it, even more so. We take action and we do things. And sometimes in this realm of palliative care, listening is the most important thing, and being comfortable with silence, because sometimes patients don't need to hear, they need to be heard. And so after he expressed himself and his concerns, we just kind of sat there in silence. And then we began to address some of the real concerns that he had, and the social worker kind of took it from there and provided them resources and about assistance, of getting care at home, and the wife getting paid for doing some of the care through Medi-Cal and different things. And and just the dealing with that on a very real and practical level, you could sense the relief that there was. You can see it in his face and in the softening of his voice. And so when we moved on to other things, which I try to talk about in palliative care, and that is, who would make decisions for you? I ask you, if you couldn't make decisions for yourself. When you came into the hospital, because your breathing was so labored, and your carbon dioxide level was so high because of your lung disease, it affected the clarity of your thinking. So if that ever happened again and major decisions had to be made, then who would be the person to make them? And he indicated, of course, his wife. And I said, well, does she know what your wishes would be if things were deteriorating? And he said yes, and she said no. They had never really had a talk about these things. And so we provided that opportunity. And one of the things I like to include in these discussions is actual clinical information about the potential benefits and the burdens, about different options of treatment, particularly things like life support, and what benefit life support would or perhaps not provide him if it came to that, and whether or not he wanted to be resuscitated when the end came. And so we covered a lot of ground in the meeting. He didn't make decisions that I would have necessarily recommended, but that's not the point. I meet the patients where they are physically and emotionally and provide them the information and the opportunity to make options and choices. I think we provided him I know we provided his wife and as well as himself a major service, because I was struck by a comment that she made at the end of the meeting, that how for so many years in dealing with this illness, because he had this illness for many, many years, that they were going to doctors for his emphysema, and how the doctors would examine him and they would prescribe him to his medications for it, and how they would admit him to the hospital when his symptoms got worse and he needed that. And so many encounters over the years. And she said, no one ever told us what to expect. I had no idea about these things that I've had to deal with and have to learn. Until now, no one ever told us these things. And so that's what a palliative care consultation, those are some of the components. And of course, they're as unique and different as every individual and family. And so while there's a structure I like to use that helps me access patients' emotional state and provides them the information, each day is a completely unique encounter.
My goodness, that's quite an experience. Thank you so much for sharing that, Dr. Goldman. I'd like to remind our audience that if you would like to share your comments, or if you have questions for our special guest, Dr. Richard Goldman, you can scroll down on the screen, and there is a comment box that if you have a question or a comment, you can put it there and press submit, and it'll show up on my screen, and I can ask it directly for you. Or you can directly call in to our conference line, which is 323-476-3672, with the PIN number 454380#. Again, that number is 323-476-3672. The PIN number is 454380#. And in doing so, you can actually ask the question or make the comment directly to our special guest. Thank you, Dr. Goldman, for sharing not only the experience of what you go through in your day and in your profession, but also for the experience of your own personal health and journey. It is so powerful when we, as laymen who are not in the medical profession, hears of a journey such as yours. Here you are, a medical doctor, a professional in the industry that's completely immersed daily in your life, and to have you share with full authenticity of what you went through and how it affected you and your family emotionally and physically, and the magnificent changes you made. I think that in itself was so powerful for each of us to hear. And now to share a piece of your day. Now, I myself love palliative care. When I learned about it through helping elders and et cetera, and having to work with palliative care teams, I am always honored to be amongst individuals like you. There is so much to learn, not just about the medicine, but about life and choices. And I thank you for your gift to society. That's magnificent.
You're very welcome. I appreciate your comments. The inspiration, though, that I get is often from the patient. I've seen, individuals in, my circumstances pale by comparison. That's not to minimize anybody's experience with serious illness and the emotional and impact of that. However, I see patients who are far more ill than I ever was and are dealing with circumstances far more difficult than I would ever want to. And the manner in which many of them, and of course is all, as varied as there are people, but there are some people that deal with this with such courage and such grace that when I leave the meetings and they thank me, oh, thank you, thank you for the opportunity, I have to thank them, because I'm not sure who has benefited the most from the meeting. In terms of my experience with some of these people, it's truly inspiring.
Mm-hmm. I always say what goes around comes around, right?
I guess so.
It's such a journey that I think everyone takes, and what you do, most people, like this family that you shared with us, there's so much fear because of what we don't know.
Mm-hmm.
And so much fear because, yes, you can go online, you can research, but it's still, we don't know what is fact and what is not fact. And I find, is it true that so many people are actually scared to ask the questions?
Yeah, and many times, I have to get through the obstacle of the family. The family, we encourage, of course, family members to be present. Excuse me. And many times families will say, we want to meet with you, but not the patient. And they want to protect the patient for fear that information will cause the patient to become hopeless. Okay, because many times most of the times the illness can't be cured. It doesn't mean that death is imminent, although many times it is, but we're dealing with incurable illnesses, and the family will say, no, meet with us. We don't want him or her to know. And I found invariably, many times I will do that. I'll meet first with the family in order to gain their confidence and credibility. However, I always offer the patient the opportunity and ask them if, is this information they want? Ask them what they understand, and do they want more information? And if they say yes, it is their right to have that, and I'll proceed to meet with them. And I've never found a patient to become hopeless with information, because the information provides them a sense of control in the process that they're going through, and provides them a sense of power. And control and power at a time like that is integral to one's sense of dignity. So much as you're beginning to experience at that stage of illness loss on so many different levels, and to be not part of that process somehow just creates a grave indignity. And information, as difficult as it is, empowers patients. And so I've never found it to be the case of the fears that families have, that the patient is going to become hopeless and just give up.
Mm-hmm, mm-hmm. It's interesting in our society, I think, where so many, really, it's the fear of speaking about what we would like done if something were to happen. And so many in my age group, they just don't even want to talk about it. They don't even want to go there.
Well, it's this is, a difficult topic to have. I don't mean to romanticize, the dying process. It's horribly difficult. Okay. And it provides the opportunity, though, to experience it on a somewhat different level, on a level that matters and has meaning. At the same time, to pursue it, on a technical level, with medicine and treatment, but also to move into a somewhat different realm that really creates connections between patients and their loved ones, to have that opportunity to engage on it on a very real level without having to pretend things are otherwise. Mm-hmm. Okay. So, so it's very helpful. The doctors, we're very much like the people that you're referring to for the most part. We don't like to have these conversations, and many doctors are uncomfortable. And that really is what palliative care, I think, has stemmed from, is that the need for these conversations and the need to train doctors in being able to be comfortable in having them. And so now palliative care is a part of medical curriculum in probably most medical schools now. So doctors can begin to have some sense of comfort. How do you talk about bad news to patients? Okay. And so doctors have, as I mentioned, we have this mind frame that we have to do something. We have to do something. And sometimes, as I said, just being present and being attentive and listening is really what's needed by the patient from a physician.
Do you find that you've had patients in the palliative care that have made a decision, for example, and chosen a treatment, and then after a certain time, whether it be weeks or days, that they choose to change the direction?
Yes, absolutely. And that's really one of the major benefits of engaging in patients that we know have incurable illnesses early on, because as things change, so can the goals. And so the goals may be to pursue an aggressive form of chemotherapy, let's say for a cancer patient, that provides them the opportunity of slowing down the progression of the illness and perhaps creating the opportunity to live longer. And if that treatment was not successful or the benefits are now wearing off, then we have to sit back and reassess, okay, what's our next step? What are the options now? And so if we can, initiate communication relatively early and maintain it, that's the benefit of having outpatient palliative care programs. We don't have one yet, but they're developing them also in different areas, that we can be a companion to the patient and the family, through the course of the illness. And as things change and as goals change, then what we have to offer the patient, can also change along with it. And so many times we'll have that opportunity, to provide the reassessment with the patient and allow them to make choices more consistent with the illness at that stage, and of course, their own values.
And with the knowledge that they can make choices and they can change what they've chosen, that must give the family a lot of relief.
Absolutely.
Truly empowering them.
It does. As you mentioned, we're so unfamiliar with this process where 100 years ago, death was not quite as feared. It wasn't wanted, of course, but it wasn't as feared because it was much more familiar to people. And now, most people have not seen, a dead body except in the funeral home. Mm-hmm. And so being a companion to the patients and the families along this way is tremendously helpful to them. It's obviously the most difficult time of many of their lives, and to have a number of resources to guide them along. And many times at that point is when, is the interface of palliative care and hospice, when it becomes clear at a particular point in someone's illness that pursuing active treatment is no longer beneficial, then the role of hospice becomes very, very prominent, and many times we'll make referrals at that stage, to a hospice organization, and they'll assume the care of the patient, in the final weeks or months of their life.
Isn't that very difficult? I mean, I might find that a little difficult, that I start off working with a team of people who are caring and loving and empowering me, and then the last days of my life, the whole team shifts. It's like, wait a minute, where's my original team?
Yeah. Well, yeah, in my situation, and probably in most palliative care situations, we'll see the patients. I'm a hospital-based consultant, and so we provide that, and the resources that we connect them with are often as outpatient. But many times they'll come back to the hospital, and then we'll have the opportunity to revisit with them, and again provide them the necessary resources. So many palliative care teams are intimately involved with the patient, while they're staying in the hospital, and aggressively managing, their symptoms. I take a somewhat different position, not because it's not necessary, but just in terms of where I want to focus, my skills and my abilities is really in this area of meeting and communicating. And so I really can't do active clinical management of symptoms at the same time of being available to the 3 to 4 families with whom I meet each day. Mm-hmm. So hospice does a wonderful job, though, in most cases at that point in time. So I think family members are very accepting of them and appreciative of their work.
Mm. Well, that's magnificent. Thank you so much. Glenn, I think we're almost at the top of our hour here. And I know that you have another question that you need to ask.
I have a few quick questions. Rich, does insurance cover palliative care?
Yeah. I'm a consultant, just as you would call in a cardiologist. If you need, the expertise of a cardiologist, your insurance would cover for that specialty consultation. And so insurance covers, for the most part, my consultations.
Mm. We're speaking with Richard Goldman, who is a physician who was an emergency physician, practiced family health, and now is the medical director for palliative care services in St. Joseph's Hospital in Northern California. We always ask our guests, Richard, for a special health tip, something that you on your journey have figured out. And you've had a pretty amazing journey, seen a lot of things. I'm anxious to hear what kind of a health tip you have for us.
Boy, that was the most challenging part in preparing for this. And I didn't have anything until doing a meditation this morning, actually. And then it came to me. Okay, isn't that funny? I was thinking about, saying, eat more vegetables or things like that. And so here's my tip. It's take the stairs rather than the elevator. And that has meaning on many levels. Now, obviously, one is that it's physically healthier to be active and to move your bodies and, to go up the stairs. But it also provides an opportunity to be aware of what we have often in our lives of habitual and reactive behavior, an automatic resistance to something that we perceive as uncomfortable, we don't want to do. And so when you're faced with the choice of the elevator or the stairs, one would naturally say the elevator, but that's an opportunity to encounter, a certain reactivity that may just be habitual. So taking the stairs rather than the elevator provides us that opportunity to encounter resistive or reactive habitual behavior. And taking the stairs rather than the elevator can serve as a metaphor for life, and that is to be engaged in it. Because each day, I see people who are in circumstances, they're moving towards the end of their life. And so that provides me each day a reminder of how blessed I am, how grateful I am, how all that I have in my life, and to be aware of that, and that the issue is not that we should be fearful of death, but that to be in celebration of life, and that how we want to live the life from moment to moment, and that the choices and the options that we have, things that matter, really demand us to be actively engaged in our lives and consciously engaged. And so take the stairs rather than the elevator, however you want to, on whatever level you want to interpret that. That's going to be my medical tip for the day.
And that's a beautiful one. Is there and thank you for that. Is there anything that you haven't mentioned that you do want to mention to us, or we've covered everything, or we could look forward to another show with you at some point?
I think pretty much covered the highlights of this, and thanks for the opportunity. I hope that people find it helpful and informative.
I think no question about that. I would like to thank our very special guest, Dr. Richard Goldman, the Medical Services Director of Palliative Care, for sharing his wisdom and expertise on his journey. I'd like to thank all of my teachers and all of my healers to allow me to be on the journey that I'm on. And thank you, Christina. I'm looking forward to meeting with all of you next week as we search on Magical Medical Tour through another quadrant of the healthcare galaxy. And until that time, thank you very much, Richard, and I wish everyone optimal health.
Thank you,
Glenn.
Thank you very much. Oh, it's been an honor having you on our show, Dr. Goldman, and
thank you.
And sharing your journey, which we're so grateful to you, really, and your team. So
thank you.
We hope to have you back on. We'll think of something.
Okay.
I would like to thank each and every one of you for joining us on this new platform of education and information. We're grateful for your continuous support and look forward to hearing your feedback on how we can serve you better. We invite you to join us live every Tuesday for Magical Medical Tour at 10:30 a.m. Pacific Standard Time, 1:30 Eastern Time. Wednesdays for Trinity of Life at 11 a.m. Pacific Standard Time, 2 p.m. Eastern Time, followed every other week with Flowing into Awareness with Anatara. You can also contact Dr. Glenn Woolman at myyogahub.com/GWoolman or follow him on Twitter at Glenn Woolman, and of course through his own website, glennwoolman.com, where we do encourage you to learn about his metaphor square breath. Until we meet again, namaste.